Let's see if we can put this in the correct mode. Uh-oh, is it only sharing half of my screen now? Or are you seeing it all?
No, it's only half.
Okay. Let me see if I can correct that. Is that better?
Yes.
Perfect.
Okay, great. All right, so thank you again. Today I'll be talking about updates and therapeutics for scarring alopecia. It's often an area that we feel kind of hopeless, but there are many new medications down the pipeline. And I'll focus on CCCA because one of my passions is certainly serving skin of color patients. This is something that I see very commonly in Atlanta. And I feel like there have been a lot of changes in the past, like 8 to 10 years in terms of our understanding of CCCA and how we manage it. And thank you for the kind introduction again. So I have no relevant disclosures aside from thank you to my patients for allowing me to share their photographs. Just as an overview of what we'll talk about today, kind of intro with some what I call overlap therapeutics. There have been kind of a big mushroom of things we can use and how we use them in terms of just regrowing hair. So we'll chat about those. Then we'll jump to therapeutics in FFA and LPP, touch on dutasteride, finasteride, naltrexone, maybe some others that you don't use quite as commonly. And then end with CCCA, how our understanding of the pathophysiology has changed, some clinical findings suggestive of disease activity, as well as the role of hairstyling in CCCA. So I just want to start by saying, treating scarring alopecias is hard. Sometimes it feels kind of hopeless. However, one thing that I'll say from the clinician perspective is although I'm telling my patients, our goal is to stop progression, mainly we can get back 10 to 20% of your hair in scarring alopecias. In the back of my mind, I know that often there are concomitant hair loss disorders that I can treat and I can regrow hair. So I'm always aiming to do that as well. So you can make symptoms better of seborrheic dermatitis. You can make the itching and scaling better. So always think about cyclopyrex, ketoconazole, and some of your less drying products like royal oils or Neutrogena T-gel for curly textured hair. I have plenty of options for androgenetic alopecia, right? So if I'm seeing miniaturized hair follicles, vellus hairs, pigtailed hairs, I'm going to add on my oral minoxidil, spironolactone, finasteride, or dutasteride. If I'm seeing traction alopecia, that's where I'm going to talk about hairstyling practices. And then oftentimes in CCCA patients, I may also be seeing acquired trichorexis nodosa, and that's where I'm really delving into having that conversation on hairstyling. So whatever you can do to intervene, think about really focusing on that and know that, you can stop the scarring alopecia, but when it comes to regrowing hair, there are often other types of hair loss that we can improve upon with our therapies that we have now. And just to highlight this, so this is a patient who came into the office. Her pre-photos are in the background there. Sorry, the animation isn't seeming to work, but my initial thought was, well, this is early CCCA. Plus, I can see that her hair looks dry. Her hair is different lengths. It's broken. Really, the visit focused on talking about hair care practices. Are you deep conditioning every 2 weeks? Are you using coconut oil to your hair before you're washing? How are you styling your hair? Any heat styles? Are you using a relaxer? So this is where it becomes relevant. And really all I used was topical steroids for her and changed some hairstyling practices. And she was over the moon with how her hair looked afterwards. So really being able to focus in on what you can change is important. With that being said, there are a couple of medications that I'm using much more nowadays, and I call these the overlap therapeutics because I'm using them in my scarring alopecia patients, but we know they have great evidence in non-scarring or androgenetic alopecia. So I know you've had patients that have come in and asked about this New York Times article. If I asked for a show of hands, I feel like I would see tons of yellow hands in the corner. So everyone wants a little bit of oral minoxidil nowadays. right? So, and that came out in August 2022, and I've been using it so much more. So this is a study published in 2021 on low-dose oral minoxidil. It was a review of 17 studies and a total of 634 patients. And although it's mainly used in androgenetic alopecia, there's certainly evidence in chronic telogen effluvium, lichen planopilaris as well. It is important to note that the dose is a bit different for women and men. Not to say I do not use it up to 5 milligrams in women, but many of the studies use a max dose of 2.5 for women and 5 milligrams for men. As you'll see in this review, if you get a chance to read it, and I'll just briefly summarize, there are no standardized ways to really assess the efficacy across these 17 studies. But there are some, for example, one study showed 100% benefit for some. So it does work. And I think the best thing about low dose oral minoxidil is that it's relatively safe with few side effects. So in this review from Bano Galvan, published in 2021 in the JAN, of 1,400 patients, very low side effect profile, mainly, and I'll say this is true clinically as well, hypertrichosis is going to be what stops some of your patients from using it. So 15% will experience hypertrichosis. Also, you have to counsel about lightheadedness, dizziness, swelling or fluid retention is a big one, headache, and some will experience periorbital edema. This wasn't enough to stop many patients from using the low-dose oral minoxidil, however, so oftentimes you can treat through. And then I love this image because it gives you a sense towards the bottom of the timeline. So for example, you're normally going to experience tachycardia and lightheadedness within a week or so of starting low-dose oral minoxidil. Headache, fluid retention, and hypertrichosis are going to take a bit longer for you to present. So typically when I'm prescribing, I start at a dose of half a tablet, which is 1.25 milligrams, and I'll increase to 2.5 milligrams after 2 to 3 weeks. Thinking that that will at least let me know if the patient's having any lightheadedness, tachycardia, or headache. I see there. Perfect. There are some questions. If it's okay, I will jump to the deep conditioning question towards the end when I talk about hairstyling, if that's okay. Fantastic. And of course, if there are any questions or comments in the chat, please feel free to drop them. I'm so happy to answer. All right, also, I'm using more spironolactone. This was a study, it was a review done, and it looked that it's rarely used as monotherapy, and about 23% of the time we're using it for monotherapy, usually used in combination with either topical minoxidil, oral minoxidil, or iron supplementation in androgenetic alopecia, but I am using it in other forms as well. Important to note, it's largely ineffective at doses of less than 100 milligrams. So I'm often starting patients at 50 and increasing to 100 if they're tolerating well. And 49% had improvement in follicular density when using at this dose. All right, great. So let's talk about therapeutics in frontal fibrosing alopecia and LPP, lichen planopilaris. So just to take a brief detour and overlap with my skin of color theme. So frontal fibrosing alopecia can be a bit tricky in skin of color patients. I think that's because often there's an overlap in the presentation with frontal hair loss that you can see from traction alopecia. Some clues you can look for. So typically with FFA, you're going to see lonely hairs as opposed to the fringe sign, kind of a maintenance of hairs around the temples or around the frontal hairline, and then a skip area with significant loss, and then back to pseudonormal density, which is what you'd see in traction alopecia. If you're ever having trouble distinguishing though, oftentimes patients will have other features. So look for those facial papules, right, that represent fibrosed vellus hairs on facial skin. Look for prominence of your frontal veins. You can also see overlying rosacea, so like central facial redness can be seen in FFA. And then especially in skin of color patients, look on the neck, axilla, lower face, temples for any hyperpigmented macules. So FFA often travels with lichen planus pigmentosis in skin of color patients. And there was a publication in 2021 that talked about differences in presentation of FFA in skin of color patients. And what they found is actually there's a younger age of presentation, so 53 versus 63 years old, increased symptomatology, so increased itching with an odds ratio impressive of over 18. Increased rates of facial hyperpigmentation, so 57% versus 3%, and they're less likely to have follicular hyperkeratosis. So when you're looking at your findings on trichoscopy, less likely to see perifollicular scaling or hyperkeratosis. So this is an algorithm presented by Dr. Shapiro. He also is at NYU and a fabulous mentor of mine. So many of the treatment algorithms that I'm using are coming from him. Although I do vary in some ways, and I'll talk about that a little bit later on. But there is great evidence for 5-alpha reductase inhibitors and FFA. So basically following his treatment algorithm, if you have anyone who is rapidly progressive coming in with, this happened fast, I'm having significant itching, you're, grossly seeing erythema, and you're dermoscopically seeing perifollicular erythema and scaling, think about starting a slow prednisone taper to kind of shut down that inflammation. So here's where you'd see his rapidly progressive arrow. He says he starts around 40 milligrams per day for a week, and then we'll taper over the course of 8 weeks. If it's slowly progressive, or so, you may have symptomatology, but this has been going on for years, think about how extensive it is. So if you feel that this is kind of earlier stage, less than a centimeter recessed, you can start topical tacrolimus. So he calls it TCM protocol, topical tacrolimus, topical clobetasol, and then topical minoxidil, all used to the frontal hairline, one right after the next. Also doing injections every 4 to 8 weeks. He recommends a dose of 2.5 milligrams. I will say I frequently use fluocinolone and clobetasol at the frontal hairline. It's a bit tricky to know whether the atrophy you're seeing is a result of the disease in FFA or a result of the injections and the topical steroids. So my suggestion would be take many clinical photographs when you start off. I also take measurements. I'm using a ruler from the lateral canthus to the first area of hair on either side, as well as from mid-eyebrow point or mid-glabella to the center hairline. If you have more significant hairline recession greater than a centimeter, consider the same topical treatment, but also 5-alpha reductase inhibitors. I'm sure you're probably also using Plaquenil at weight-based dosing. Another option is doxycycline. He does mention pioglitazone. I'm not using that as frequently just because of the risk of bladder cancer that was confirmed a few years ago. And then naltrexone is another option as well. If you have someone with significant inflammation, you can't seem to shut it down, you've already exhausted your prednisone options, I am doing things like Celcept and methotrexate for those more persistent inflammatory cases as well. So just to delve into some of the evidence on these things. So this is a case of 224 patients, a series with 24-month follow-up published in 2021 in the JAD. And they found that dutasteride at a dose of 0.5, 5 to 7 times weekly, which is important to note, this was dose-dependent findings, had a stabilization rate of 62%, 64%, and 62% in each area in the scalp. So I am very quickly turning to 5-alpha reductase inhibitors in FFA, and I will say also in LPP and CCCA, increasingly so. Important to note here that dutasteride can be bit of a challenge to get your hands on, but we do think it's more efficacious than finasteride because of its ability to work on both forms of the 5-alpha reductase receptors. Another important point is that dutasteride has a much larger half-life, much longer half-life than finasteride. So I'm not using this in my pre-menopausal women. I'm also, if there's a patient who's hesitant with the sexual side effects or hesitant when it comes to mood issues, I would opt for finasteride versus dutasteride because dutasteride would have a several week half-life and would stay in their system much longer. All right. So next, thinking about oral retinoids. So there was a retrospective cohort study of 440 FFA patients and found that both isotretinoin, excuse me, and acitretin, when used for a prolonged period of time, had some benefits. Isotretinoin in 72% of patients proved to have no further progression of their FFA. And similarly, 73% of patients on acitretin had no further progression. So I do use this. I mean, isotretinoin is a little bit more easily accessible now that there have been changes to iPledge. A lot of patients, though, are hesitant just because of all of the side effects. So usually I'm turning for my to dutasteride first. You can also consider the use of excimer laser or 308 nanometer laser. We know that this is beneficial for inflammatory conditions. It's thought to modulate T cells and cytokines. There have been mainly 2 studies published on it. Both have included LPP and FFA patients. One had improvement in symptoms and hair growth. However, it was sustained only in 2 out of 13 patients. And the second study, only 3 out of 13 patients responded with increased hair growth and decreased symptoms. So doesn't look terribly promising. I would say that it's something that I would consider using if I've exhausted all of my topicals and I'm still seeing evidence of perifollicular erythema and scaling, or in my patients who are hesitant to use orals and really would rather stick with something either topically or used locally on the scalp. All right, so now we'll move to LPP. So similar algorithm here in terms of LPP. I will say, again, he mentions for an oral prednisone burst for rapidly progressive LPP. You'll notice that when giving the intralesional steroid increases to 10 milligrams per mil monthly, he's still using topical tacrolimus, clobetasol, minoxidil. Another important distinction here is that instead of turning to 5-alpha reductase inhibitors first, often we're using doxycycline and Plaquenil first line. If you're not seeing stabilization, you can add on something like naltrexone, pioglitazone. Again, I'm much more hesitant to use pioglitazone just because of the black box warning. Here's where I would probably jump to 5-alpha reductase inhibitors, or if we're still seeing significant inflammation, I'm using immunomodulators such as Cellcept, methotrexate, and isotretinoin. So the evidence for naltrexone is basically a single case series of 4 patients. We know that low dose naltrexone is used for anti-inflammatory effects, as well as treatment of itch and other conditions. In this study, they looked at naltrexone, I believe, alone, as well as in combination with pioglitazone, and there was stabilization of hair loss and resolution of inflammation after 1 month in these patients. So pioglitazone is a PPAR gamma agonist. It's used in diabetes. It's probably where you've heard of it. In a study of patients refractory to prior therapies, 22 patients, 72% had halts of disease progression, and about a quarter of them reported hair growth. I want to put on your radar a condition that you probably have come across, although may not have had the name to describe it. So this is fibrosing alopecia in a pattern distribution. So often what you see are patients who have kind of diffuse hair loss in the androgenetic pattern, so at the crown of the scalp, But when you look on dermoscopy, you're also seeing perifollicular scaling and maybe some perifollicular erythema. It tends not to involve the eyebrows or lashes or body hair, but it is scarring, and you'll see that with loss of follicular ostia. Again, when you zoom in, you are seeing that there's some variation in hair shaft diameter when you're looking on trichoscopy as well. So these are kind of the perplexing cases where you're saying, wow, I'm definitely seeing features of androgenetic alopecia, but I'm also seeing features of scarring. And I used to biopsy these quite frequently to confirm that there was evidence of scarring. But now that this entity has received a name, I'm doing that a little bit less so. So this is fibrosing alopecia in a path distribution. So here's some photographs of that. You can see decreased density at the crown. Be pretty convincing, right, for androgenetic alopecia. But when you zoom in, you are getting perifollicular scaling that's seen. And one thing that I always like to say is if you're having trouble realizing if there's perifollicular scaling or not, always take time and maybe even first kind of establish a baseline of what that patient's hair density looks like at the occipital or temporal scalp. Evaluate whether or not there's significant variation in hair shaft diameter, so the thickness of each hair. Is there variation in other areas? Do I see scale around each follicle in what I would deem a normal area? So again, occipital or temporal scalp. And just kind of establishing your baseline before you go to the crown or before you go to a particularly inflamed patch will help you get a sense of whether or not there's perifollicular erythema or scale in those areas, as well as loss of follicular ostia. Check the chat. Agreed. There's a good question in the chat regarding hair loss as a result of oral retinoids. Is this pretty infrequent? I'm not sure of an exact percentage of how often this happens, but I have seen this happen enough that whoever I'm starting on oral isotretinoin, I'm also counseling about possibility of hair thinning or hair shedding. Now, for my younger patients who are started on isotretinoin for acne, for example, I'm usually telling them that that's reversible. I wouldn't so confidently say that for my older patients who I'm starting on something like isotretinoin or acitretin, however. But yes, I certainly have seen hair loss as a result of oral retinoids. Great question. Okay. All right, so that was kind of a run through of some scarring alopecias being LPP, FFA, and kind of our overlap therapies. So now we'll jump into one of my favorite disorders to diagnose and treat, which is central centrifugal cicatricial alopecia. And many of you are probably thinking, why would this be one of her favorite things to diagnose and treat? And that's because I think that many of these patients come in feeling as if, they've already exhausted all of their options, they feel hopeless, but we do have therapies that we can use, and we have changes that we can certainly make. So CCCA is very appropriately named. We all know this is a scarring alopecia that starts at the crown of the scalp. So for some people, that's more posterior. For others, that's more anterior. And it spreads outward over time. Oftentimes, you're getting that shiny appearance with loss of follicular ostia. And this is an end stage case of CCCA here. Now, why is it an exciting time for CCCA? I think it is much more so because we've had significant advancements in our understanding. So when this was initially described, it was called hot comb alopecia. And it was thought that the use of a hot comb, which is literally a metal comb that was heated either on the stove or with an electric apparatus, which was then used on the scalp with usually an oil or grease or ointment-like product. It was used to straighten hair and break bonds. And it was thought that these patients may be causing trauma because the heat would make its way down to the hair follicle and cause fibrosis. However, over time, you'll notice that it shifted from hot comb alopecia, so hot combs being the culprit, to then maybe, chemical relaxers are the culprit, because there was a shift from the use of these heat styling to chemical styling. So chemical relaxers use a chemical to break disulfide bonds and straighten hair. And then what we noticed, however, is that there was a trend toward what we call natural styles. So avoiding chemicals at all to straighten hair, and even avoiding heat to some degree to style hair, but yet we were still seeing CCCA. So if there is a reliance on this environmental trigger of hot combs or chemical relaxers, it doesn't make sense necessarily that the community is using them less so, but still developing CCCA at an alarming rate. 5% of Black women develop CCCA. And also, another observation was that this was happening in very young people. So I think it's been described even as early as age 11. So how much traumatic hair practices could really be going on before age 11 for us to develop this type of scarring hair loss. It was then named follicular degeneration syndrome based on early desquamation of the inner root sheath that's found on path. And then it was renamed in 2003 to central centrifugal cicatricial alopecia, which really describes the clinical findings. And then a lot of things came into question in the early 2000s, and a couple of studies looked at fibroproliferative genes and found that there was upregulation of fibroproliferative genes, as well as an association with uterine fibroids. And now there's a known association with type 2 diabetes, and a Sentinel paper published in 2019 in the New England Journal that identified a mutation in PADI3, which is responsible for protein modification. And so now our thinking has shifted a little bit. This is not fully attributable to styling practices, and more so is probably a genetic condition that has some association with fibroids and diabetes. And more information is certainly needed to fully elucidate why this is happening. But yet we know this is a scarring form of alopecia. So again, I'm telling patients our goal is to halt progression. We have limitations in the amount of regrowth, usually 10 to 20% is what I'll say. There has been descriptions of itching, burning, and tenderness, although many of my active CCCA patients do not have symptoms at all. The itch is not found to be histamine induced, so I'm not using antihistamines often in these patients, and it's estimated to be occurring in approximately 5% of Black women. There are reports in men, so if you're suspicioning CCCA in men, it definitely is a possibility. Happens usually middle age, 30, 40, 50. However, there are reports in children even as early as age 11. So this is a patient that I followed for 3 years now, and at age 13, she presented with this alopecia patch in the center of her scalp. She's been managed on Plaquenil, triamcinolone, as well as topical treatments, including minoxidil. And she's regrown some hair and very happy with where she's at. And so one of the Sentinel studies in questioning our understanding and the role for genetics came out of South Africa, actually, and was published in the JAD in 2014. And they did a pedigree analysis of 14 index African families with 31 immediate family members screened. And what they found was that there may be an autosomal dominant inheritance pattern to CCCA. The average age of onset in their study was 41 years of age. And there was an association with increased tension, so braiding and weaving practices. And then, of course, we're probably all familiar, excuse me, with the Sentinel study from the New England Journal of Medicine. Excuse me, I think that might be a package. From the New England Journal of Medicine, which highlighted a variant in PADI3 and CCCA. So essentially what they did is they looked at a discovery set of women, so 16 women with alopecia, and they did generalized exome sequencing to identify anything that could potentially, any gene that could potentially be altered or variant, right? And what they found in that those 16 women, I believe it was 31%, 5 patients had a mutation in PADI3, which is peptidyl arginine deaminase 3, which is a protein that's involved in hair shaft formation. So once they identified PADI3, they then looked at a replication set of 42 patients and found again that there were, I believe, 8% of those patients had mutations in that gene. So there's some more to be determined, but there's definitely a gene variant that seemed to be associated with CCCA. And this is another study that was done out of Hopkins. They took a handful of patients, 5 patients with CCCA, and looked at areas that were affected versus unaffected scalp. And they found that in affected scalp, there was upregulation of genes associated with fibrosis. So platelet-derived growth factor, collagen, matrix metalloproteinases that were upregulated in affected scalp. And I will say, important to note, right, we know that doxycycline has an impact on MMPs, so that might be why doxycycline has some benefit in CCCA. So overall, how I counsel my patients now is I say you probably have this genetic predisposition to making fibrotic or scar tissue, and there's some environmental trigger that we can't quite name yet, less likely to be chemical relaxers or hot combs, maybe a high tension styling that then triggers the development of CCCA. And I frequently get questions about, is there an association with fibroids? And the answer is yes. So one retrospective review from 2018 essentially looked at a cohort of women with CCCA and found that 13% of Black women with CCCA had uterine fibroids. And when they looked at the larger cohort of women without CCCA, only 3.3% of them had uterine fibroids. So it seems there's a 5 times increase odds when you look at sex, age, gender controls, match controls. However, when they delved into this a little bit further, they found that of 16 subjects with CCCA, 8 with fibroids and 8 without. When they did gene expression profiling on those 16 subjects, there were 2 genes that did seem to have a statistically significant fold change in expression. However, they didn't really pan out to making sense in terms of a fibrosis pattern. So it's likely that CCCA and fibroids are not causally linked, but instead represent these concurrent fibroproliferative disorders that are happening in Black women. And there's a recent article from 2022 that's really important, Dr. Susan Taylor's group, but essentially it has been, thought of before that diabetes may be increased in women with CCCA. And recently, a retrospective chart review found that 37% of women with CCCA had diabetes mellitus, and that was and that's increased odds ratio even after controlling for obesity. It's important to know. All right, so how am I establishing a diagnosis of CCCA? So I will stop here to say that I am infrequently biopsying scarring alopecias. I find that dermoscopy or trichoscopy is often enough to make the diagnosis. And you can often get frustrated because scarring alopecia will come back as such and not really help you distinguish between CCCA and LP clinical distinction. I'm more so using biopsy to help me delineate whether or not there are any features of scarring on histopathology. So if I'm looking at someone and I'm saying, wow, it looks like there's loss of follicular ostia, or I can't quite tell if there's perifollicular erythema or just background erythema, or if there's interfollicular scaling versus perifollicular scaling, that's when I'm doing the biopsy. Or if there's a patient who I've tried on several therapies and I'm not quite getting the response that I would expect, that's when I'm doing a biopsy. But you can often make a clinical diagnosis of CCCA. So this is the patient with CCCA, and I wanted to point out here that sometimes CCCA will have kind of patchy hair loss at the crown of the scalp, so it's not always going to be totally smooth with hair around the periphery. You often get patchy hair loss, as is seen here. Also, whenever you see styling, always be on the lookout for thinking, well, could there be concomitant traction that's happening? So I'm going to be looking for hair casts on dermoscopy here to let me know if there's any traction that's also occurring that I can counsel on. Whereas this is an example of, near complete loss of hair density at the crown. So instead of this being patchy, this is near complete loss. So I have seen it present in both forms. There is a scale that helps us quantify or, objectively keep track of where patients are in terms of their central scalp hair loss. I will say that this is the Central Scalp Alopecia Scale. So it's not only used for CCCA, it can also be used for other forms of central scalp alopecia, such as androgenetic alopecia. So 0 would be no loss. Then we have 1, where it's barely perceptible, 2, more so, 3, 4, and 5 is your most extensive. Now the A and B will correlate with whether the loss is more anterior or whether it's more posterior on the scalp. I will say for a patient who's perhaps at stage 3, 4, 5, I'm also not likely going to be doing a biopsy. It's really these overlap cases where I'm saying, well, is this perhaps androgenetic alopecia? That's where I'm more so using my biopsy tool. Dermoscopy is incredibly helpful. When you're looking at the scalp of a skin of color patient, you will see network on dermoscopy, and you'll also see, I'm not sure, is my pointer working at all?
Yeah, we can see it.
Okay, beautiful. So you'll see network on the scalp, and you'll also see several white small glands, and these are just glandular openings. This is normal scalp. Well, this is affected scalp, but these are normal findings on the scalp. What you start to look for pathology is this patchiness to the coloration, right? So dark brown areas within these white stellate areas. Also, look around for what looks like a normal terminal follicle to get a sense of what your follicular opening size should be. That will help orient you to know, well, this is a follicle, and these are areas without follicles, so these openings are probably glands. So here I've lost follicular openings, right? And this is another example. So here you see kind of patchy coloration, as well as these white glandular openings. But here we have the larger follicles, and these are perifollicular halos. So these are the most sensitive and specific findings on trichoscopy for CCCA. You can see these in other forms of scarring alopecia, but you are less likely to see perifollicular erythema and scaling in CCCA than you are LPP or FFA, for example. So perifollicular erythema is only noted in 61% of cases, whereas these halos are noted in 94% of cases of CCCA. I will make note here, there are also some hair casts in this image. So this is a patient that I would also be talking to about how they're styling their hair. And here's another example, a close-up of these perifollicular halos. You see kind of the white patches and asterisk-like brown blotches as well that have been described in 24% of cases. This is a better picture of network. You can see the glandular openings. You can also see follicular openings. This is interfollicular scale. So when I'm seeing this, I'm also going to counsel about treatments for seborrheic dermatitis. And here in this photo, you can see some perifollicular erythema. All right, so how do I treat CCCA? There are many factors that are going to come into my consideration when deciding on a final treatment plan. How rapidly is this progressing? Do you have any other hair loss disorders I can treat? What's your experience with it, right? So I have patients who are stage 2 who are very distraught by their hair loss. And then I have patients who have stage 5 CCCA or essential scalp hair loss, and they come in just wanting to know their diagnosis and are totally okay with wearing a wig. So then I'm not going to try necessarily everything in the book for them, right? So also it's important to consider what their experience is with it. Mostly though, I'm thinking about what are my signs and symptoms of activity, and this can be very tricky in CCCA because you can have progression of the disease without necessarily having symptomatology or clinical signs that are that evident. So things that definitely let me know that the disease is active are sensitivity of the scalp, itching. Also, some of your earliest signs of CCCA will be breakage at the crown. So this commonly comes up if you have a patient with locks in their scalp. This is, you know, it's interesting, just the center of my scalp, these locks fell off. Then I'm thinking, okay, CCCA. If I'm looking and I'm seeing breakage all over, I can think maybe that's acquired trichorexia nodosa. If I'm seeing breakage mainly focused on the scalp, I'm thinking early CCCA. Also, another part of my exam is to kind of push on the center of the scalp. And you notice there's a bogginess that likely represents inflammation that you see in CCCA. Those are patients that I definitely want to inject to try to decrease that inflammation. Of course, perifollicular halos, erythema, scaling, those are all signs that treatment is needed. So what's my algorithm? So I also use TCM, so topical tacrolimus applied first, then clobetasol, which I'm not hesitant to use on the scalp. I do let patients know that there might be some hypopigmentation, and if that's the case, to stop it, as well as topical minoxidil. Give a disclaimer here. I often now start oral minoxidil because it's so easy and decreases the number of topical treatments that a patient needs to use. I will do intralesional injections every 4 to 8 weeks, and I accomplish that by actually double booking some patients and appointments just for what I call an injection clinic visit, where they're just coming in, boom, boom, getting injections. I use a dose usually of 3.33 because I have seen atrophy at 5, especially in skin of color patients. And then I'm mainly starting with oral doxycycline, 100 milligrams twice daily for 3 or 4 months, or Plaquenil at weight-based dosing. I talked about much of this. I will stop to say that for many patients who want more of a natural route, you can consider using rosemary oil instead of minoxidil. There was one study that suggested that rosemary oil has similar efficacy to 2% minoxidil. However, disclaimer, many of these essential oils, if they're not diluted with a carrier oil, such as olive oil or coconut oil, they will cause irritation to the scalp. I almost universally will recommend intralesionals if someone has any itching, burning sensitivity, if they're reporting breakage or rapid progression, or if I'm seeing any signs of disease activity, such as erythema, scale, halos on exam. Vibrational device helps a lot with patient comfort. And this is one example of patient treated mainly with just topicals and intralesionals. We know that doxycycline has inhibition of matrix metalloproteinases, and that might be how it's working here, whereas Plaquenil works as an anti-lymphocytic. Also rarely, not frequently at all, I'll use other things such as mycophenolate, oral steroids. I would also add that 5-alpha reductase comes in handy here as well. There was a recent publication of 2 reports of topical metformin, 2%, 10%, excuse me, being applied with good results and efficacy. I will have this compounded. It's not expensive at all. I use ChemRx in Philadelphia. This is another option for patients who've already tried orals without much success, or who want to just stick with the topical routes. I will often turn to topical metformin. And PRP has been described as having some mild benefit in scarring alopecia, so I will use it in CCCA as well. Now, if I feel that I have, decreased inflammation, there's less perifollicular erythema, less scaling, fewer halos that I'm seeing and my patients reporting that their symptoms have improved and they don't feel that it's progressing, then I will stop doxycycline, usually after 3 or 4 months. I usually continue patients on Plaquenil. I will continue injections, usually for 4 to 6 cycles, so that's 4 or 6 months. But I continue my topicals, although I will drop down clobetasol to just Saturday and Sunday. Of course, I'll drop it even further if I'm seeing any signs of hypopigmentation. Then I tell them that I'm shifting to kind of a regrowth phase. So we've stopped the scarring alopecia. Now let's really focus on regrowth. This is when I'm going to add on my low-dose oral minoxidil if I haven't already, and think about things such as spironolactone, especially if I'm seeing variation in hair shaft diameter, a lot of vellus hairs. Then I'm going to try to regrow hair as much as possible. PRP is another great option for that. So lastly, I just want to focus on communication. I know that CCCA can be challenging, especially when it's not, a race concordant visit. The patient has seen many dermatologists and felt like their symptoms were kind of dismissed or they feel hopeless. So sometimes just slight tweaks in how we communicate about these things makes a huge difference. And one of those things is really hairstyling. So just want to hit the point home that we only have a few studies on hairstyling in CCCA. The first came out of Nigeria in 2005, and it was the smallest of 39 subjects, and they did find an association between chemical relaxer use and CCCA. But larger subsequent studies have not. So in 2009, a study of 101 subjects found that there was no correlation between CCCA and the use of hot combs or relaxers. However, there was a strong association between high tension styling, such as weaves, extensions, cord and rope braids, etc. And similarly, the largest study we have to date looked at 529 subjects, and that's where we know the prevalence is 5.6% as a result of that study. But they found no association between central hair loss and hot comb use or relaxers. And instead, they actually found an association between bacterial scalp infections. So how does that impact how I counsel my patients? So first, I never start a conversation with, tell me how you style your hair. I always reserve that essentially until the physical exam. Next, if a patient's hair appears healthy, so no breakage, doesn't appear dry, overall appears healthy, and they're relaxing their hair, but yet they have some signs of CCCA, right? So thinning at the crown. I don't, especially not at the first visit, I don't tell them to stop relaxers or hot comb or heat use. If their hair overall appears healthy and we're just treating the scalp with CCCA, I don't necessarily jump into hairstyling practices. I also find it's nice to kind of just open up with, oh, tell me how you style your hair, or at the start of the physical exam, oh, I see your hairstyle is plaits. Is this a normal style for you? So being able to name the different hairstyles really goes a long way with patients. And there are some resources I'll point to towards the end that can help you become more familiar with those. So some other phrases to help manage expectations. So I avoid things like inactive or burnt out when communicating with patients, because even though clinically it may be inactive, they still very much feel as if their disease is impacting them. So for them, that term may be a bit off-putting. Also, it's hard to say that CCCA is burnt out. This is one of those elusive conditions that sometimes isn't symptomatic, but yet is still progressing. So even though we're not seeing signs, it could still be ongoing. So it's hard to make that call as to when things are burnt out. So I tend not to use that phrase either. I love to say at every visit, so our goal is always to stop further progression. Usually the max I can get you back is 10 to 20%. I would always hesitate to overpromise and underdeliver. So I'd rather give that message and have more success in regrowth than to do the opposite. So regardless of the stage, if someone comes in really wanting treatment for their hair loss, so even at stage 5, I will give them treatment. So usually I will start with topicals. So for someone who's stage 5 CCCA, in a wig, very bothered by it, I'm going to say, okay, I totally understand. This is really bothersome. This impacts your quality of life. Let's, start with topical therapies. So I'm doing topical tacrolimus, clobetasol, minoxidil. And I'll say to them, is your goal to get out of the wig? And oftentimes they'll say, yes, I want to regrow my hair, right? And that's totally understandable. So then I'll say, okay, it usually takes us a good 2 years to really know how any therapy is going to fully kick in when it comes to hair growth. So let's give this, 12 months to 2 years, and then you and I are going to have the conversation as to how you feel about getting out of a wig, because it's onerous to you to come in to visit me, to get injections, to apply a cream every night. So let's revisit this and see how you feel about this commitment versus how much we've regained in 12 months to 2 years. And I've had those conversations, and although they're tough, patients do kind of shift their focus and say, okay, I realize now I'm not getting out of a wig. So let's meet each other where we're at. Also just, asking what are your goals can be certainly helpful for you to gain insight as to what the patient's expectations are. And then when I reach a patient who I feel like is continuing to come in to see me and they're not quite getting we're not getting anywhere in terms of regrowing hair, I'll say, it's a huge commitment for you to come in to see me, both time-wise, financially. We have to balance this. What more can we do? How do you feel about where we're at? And oftentimes that gets the patient to start to think about, maybe I have to move into acceptance phase, right? And then just oftentimes you'll hear a lot of self-blame. I can't believe I've been using relaxers for this long. I was told I need to stop relaxers. I think it's all very fair. Our understanding has shifted so much. These are conversations that have to happen very gracefully and very sensitively. So just acknowledging that our understanding has changed recently, and we're not exactly sure what the environmental trigger is, but how comfortable are you styling your hair in XX style is a great way to ask patients about hairstyling practices. Here are some patient-oriented resources. So Dr. Crystal Agu has written a couple of books now on hairstyling that includes recommendations for products. Skin of Color Society has wonderful education documents, and they have a QR code that you can use. Dr. Lindsay similarly has a textbook as well. So I have significant overlap in how I treat cicatricial alopecia. However, slight tweaks, although majority of my patients are going to be started on topical medications as well as intralesionals. I'm really turning more towards doxycycline, Plaquenil, first line for my LPP and my CCCA, dutasteride more so for my FFA, maybe even LPP. Second line, I'm thinking about things like topical metformin, which is unique more so to CCCA, naltrexone, which is more so for FFA and LPP. I'm using my overlap therapies, use oral minoxidil, use spironolactone, use PRP in all these patients if they're interested. And dutasteride is another great overlap. Dutasteride or finasteride is another great overlap medication as well. So significant overlap, consider other disorders that you may have success in treatment. Be ready to counsel about the association with fibroids and diabetes, as well as our understanding of hairstyling and CCCA and the growing role for genetics and fibroproliferative disorders. So thank you. I'm happy to take any questions, and I know I still owe a response on the conditioning. So if there's anything else, I'd be happy to answer.
Excellent. Thank you so much, Dr. Krueger. That was a wonderful lecture. A lot of clinical pearls, a very difficult clinical scenario to treat some of these patients. So thank you for making this much more clear. Yeah, I'd like to open it up to any questions from the audience.
Hi, Dr. Krueger. This is Austin Park. I'm one of the residents of the Navy program. Thank you for this great talk. I felt like I was an AAD lecture. My question is about low-dose oral minoxidil. I've used it about a dozen, 2 dozen times with my patients who are uniformly very happy with the results, especially because they don't like the topical minoxidil. But I'm wondering, you presented your safety data. I'm wondering anecdotally, or maybe you heard the grapevine, anyone who's had the boxed warning for oral minoxidil, the pericardial effusions from the dosing that we do. I haven't heard anything. I haven't seen anything in the literature. I'm wondering if you have, and otherwise it seems like a kind of a really easy medication to use that patients are very happy with. Thank you.
Excellent question. So I used to counsel about pericardial effusion. I do not anymore. I more so use the wording of edema. So I say there is a risk of edema. I will say I have had periorbital edema that prompted someone to go to the urgent care on 2 occasions now. I've given it out lots of times. But it was pretty impressive periorbital edema as well as lower extremity edema. I do not counsel about pericardial effusion anymore. There is one case report, I believe, of anasarca that happened at our low dose. I think it was even lower than 1.25 milligrams that happened. So I do think it's worthy of communicating that there is a risk of swelling. So I often use the term edema. The edema can happen around the eyes, theoretically in the legs, and at higher doses that they use in cardiology, it has been seen around the heart. So that's kind of how I word it to patients.
Thank you so much.
No problem.
Thank you. I think Dr. Schneider also had a similar question that you hit upon in the chat here, but also he was asking about pioglitazone and counseling on bladder cancer risk.
Yes, great question. So I almost never use this because of the bladder risk. So there was a study initially, the FDA came out, there was a smaller study that said there was a risk of bladder cancer in patients with diabetes taking pioglitazone. That was refuted. And then finally, I think in 2018, there was a larger scale study, and the FDA finally came out and said that there is an increased risk of bladder cancer on pioglitazone. So I just am frank with patients. I say that it has been found to have a slightly increased risk of bladder cancer in diabetes patients specifically, who is the med is initially prescribed for, right? But I find that often that's very off-putting, and I very infrequently use the medication for that reason, because I think we have so many other great options.
Thank you.
Dr. Krueger, this is Rich Gallo. Thanks again very much for joining us and sharing wonderful insights. I particularly liked the end of your talk where you spent time really sharing with your approach to the patient and having their expectations meet what we can currently desire. And congratulations for you to tackling this very, very difficult set of diseases in dermatology. I think, the presentation really kind of reflects exactly where we are in a situation, we think of as therapeutic nihilism, where nothing works. So sort of everybody presents everything as working. And we're constantly, faced with these types of decisions with patients. I was interested that you didn't mention JAK inhibitors either systemically or topically at all that I remember. And would love to hear, I assume that was intentional, would love to hear why. Another thing I'd love to hear your thoughts about is vitamin D, which I know gets talked about and prescribed inappropriately for patients with normal vitamin D levels above 20, yet somehow people believe it helps hair growth. So I'd love to hear your thoughts about those two things.
Yes, thank you very much for bringing those up. So you are right, I did not mention JAK inhibitors, but I think in the next version, I think it's time that I graduate to talk about JAK inhibitors. So I think I would use, so first of all, JAK inhibitors, there's a huge use in alopecia areata, right? Even though there's a significant rebound. I think we're much more limited in our understanding of how JAK inhibitors are going to pan out for scarring alopecias. I find that JAK inhibitors can kind of be a blunt instrument in decreasing inflammation. So when it comes to my rapidly progressive, significant erythema, symptoms, I often turn first to shutting it down with glucocorticoids like prednisone. I do think, though, there will probably be an increasing run. There have been some very small studies of both topical and oral JAK inhibitors in mainly LPP and FFA. So I think there's more to come when it comes to JAK inhibitors in those forms of scarring alopecia. I am not aware of any in CCCA currently. I also am not sure that I would think that it would have as much benefit in CCCA. So I'm curious to see how that pans out, and maybe I'll even think of investigating that myself. And to your second question, so when I am ordering, when I think about, vitamin deficiency in hair loss, I'm ordering it very specifically for certain types of hair loss. So for someone who's coming in with two main forms. One, so significant shedding that can't be explained, so TE-like picture. Then I'm thinking about labs, mainly thinking of my TSH, also perhaps zinc. And then also for strength of hair. So I am ordering vitamin D, ferritin, which I'll replete to 50 or 60, and ferritin, which I replete to normal. So ferritin, vitamin D, zinc, and TSH for anyone who has acquired trichorexis nodosa and or a TE-like picture. I don't think the evidence is there necessarily for a link between scarring forms of alopecia and vitamin D supplementation, as you suggest. I think you're totally spot on with that, and I'm not routinely ordering it or supplementing it for that patient, those patients.
Thank you. Do you have any other questions for Dr. Krueger?
I did want to address, there was some great questions about deep conditioning and patients with dry, brittle hair, so just overall hair health. So as you know, curly textured hair, and I know I'm over time, so do I have a few minutes on that, or you tell me?
Yes, please.
Okay. So hair maintenance for curly textured hair is much different than it is for straight hair, which is, I didn't mention it in the talk, but also when you're prescribing topical medications, be sure you ask what vehicle people would prefer. It might be very different for someone who has braids, who could easily use a solution, versus someone who would prefer an ointment. So that's another important point. But when it comes to maintaining hair health, so things to consider. One, I do recommend you shampoo every 1 to 2 weeks, regardless of your hair type. You can often do that with braids in. Now, shampoo, we often think of shampoo being very foamy to cleanse. Often when you are using, or when you have curly textured hair, shift that focus, because we want to keep oil as much as possible in curly textured hair. So instead of using a shampoo that's very foaming, you may suggest something like a co-wash or a moisturizing shampoo for someone with curly textured hair. Other tricks I have are use something like a coconut oil for about an hour or two onto curly textured hair before you wash. So there's an extra layer of oil that has to come off to help maintain your own natural oil a touch more. Many deep conditioning products are available over the counter. I recommend that patients with curly textured hair, and especially with acquired trichorexis nodosa, are deep conditioning every other week. Other things to consider are oils often do not penetrate the hair shaft. So you'll hear people say, I'm putting this oil on my hair. The only real moisturizing oils are maybe coconut oil and Jamaican black castor oil, which are small enough to penetrate. But even then, I would say you need a cream-based moisturizer. Some brands I like are Mielle, M-I-E-L-L-E, Curlsmith, and I have no financial ties to them. I just like those products. But it's going to be very dependent on the person's curl type and curl pattern and what type of hair they have and how they've responded to products. Oil also should not be placed on the scalp, right? So traditionally people will put oil on the scalp when they feel that it's dry. We know that sebum is produced at the level of the scalp. So we don't need oil on the scalp. We actually need more moisture provided to the hair shaft itself. So think about that recommendation too. So if you're going to apply something, don't apply it to the scalp, apply it to your hair. I hope that was helpful.
Extremely helpful. Thank you so much.
Okay.
Thank you, Dr. Krueger.
Thank you. Thanks for having me again. It's so awesome to see you guys virtually.
Well, we are always welcome in San Diego. Thank you.
Thank you. Take care. Bye-bye.